mainly to catch them early because it's a potential earlier intervention point. So this is the paper that we'll be discussing mostly, a topographic analysis of local OCT biomarkers which increase the risk of progression to C-RORA in 4 years by Sadda and group. So the definitions, I think most of us in this group would be familiar. The hypertransmission defect of more than or equal to 250 microns is a C-RORA, and an intraretinal hyperreflective foci are 3 pixels large at least and have a reflectivity of more than or equal to RPE. Drusen, of course, are 63 to 350 microns. Anything beyond that is a drusenoid PED with a smooth elevation and moderate to high homogeneous internal reflectivity. Then we have acquired vitelliform lesions, which are hyperreflective material that is deposited above the drusenoid PED and under the retina, and a thin DLS or a double layer sign, which we are all familiar with, which can become thick in the future. So what this paper said is that IHRF are late precursors, or can say that they are the penultimate event to C-RORA and are suggestive of RPE distress. You can see this IHRF, which is flattening the drusenoid PED very soon and causing a C-RORA. A drusenoid PED comes before the IHRF. A thin DLS is an independent risk factor for development of GA, like you can see this illustrated figure. So basically this paper said that location-specific biomarkers, that is IHRF, soft drusen, drusenoid PED, AVL and thin DLS are all associated with risk of progression to C-RORA. Now talking about subretinal drusenoid deposit, although their prevalence is 93% in geographic atrophy, since they are extramacular in location, they may not be as useful as a marker at the foveal region or GA progression to the fovea. So this is a very important paper, an old paper from the FAM study group by Holes et al. And they have talked about the margin of the FAF, which has different types of hyperautofluorescence from focal, banded, patchy, reticular. The more focal it is, the slower the progression, and the more diffuse it is, the faster the progression, like shown in this picture. There are no changes here, there are only focal changes here, and you can see the progression is pretty slow. This is a patchy hyper AF. A diffuse hyper AF is something that is beyond the margin, they go beyond to the arcades. This is a banded one, which is like a ring, and diffuse trickling, which go near the arcades and sometimes even nasally and mid-peripherally. So this is a paper that said that hyperreflective foci and FAF as a combination are much more important and as a prognostication for progression of GA. And these are some of my cases. This 75-year-old physician I have been following up for the last 7 years. Started off as small discrete hard drusen, became a drusenoid PED in a couple of years, has started developing an AVL as well, and a pigment on top of the drusenoid PED. Surprisingly, the AVL vanished. However, he has developed an RVO last week. So this is the left eye, which shows a few drusen, which becomes a drusenoid PED over around 5 years. This is an AVL that has developed, and that AVL has increased in quantity. And here we can expect GA to set in at this location next year or the year after that perhaps. So this is the AF. It was pretty focal in the initial years, but now it has started to become a little more diffuse and multilobulated. This is because of the BRVO, of course. This is the left eye, again, which was focal in the past and has become diffuse now. So this is also a risk factor in combination with the AVL that we saw. This is a 79-year-old lady with progression of a thin DLS, which has become progressively thicker in the last 5 years. There is no network on the octa, there is no flow signal here. From 2023, what happened was a large drusenoid PED developed, and these are the IHRF that are penultimate to C-RORA. You can see that this area flattened dangerously to cause a hypertransmission defect and a atrophy there. So this is the right eye of this patient, same patient. The SDD are all extrafoveal. So you can see that they are not really progressing much into GA, but here this patient is developing a thin DLS. This is the third case of a 69-year-old woman with the left eye scarred CNVM. The right eye is showing this drusenoid PED in 2016, which has flattened and caused a hypertransmission defect, atrophy, and that defect is, the defects are increasing. This illustration is to just show that IRAF and IR may be better to show the foveal preservation, and GA progresses centrifugally initially. This is a 78-year-old man.
Apoorva, can I request you to wrap up?
Yes, just 30 seconds. So this is, these are some AF images which show faster progressions. And here, again, faster progressions. They are more vertical and hence faster. So this was diagnosed as an extensive GA, but here when we saw there was intense atrophy in the top part, and down there was a diffuse DLS, and we diagnosed this case as EMAP. So we can keep this slide up and go into the discussion.
Thank you so much. Yeah, unfortunately, the whole motto of RIC is more discussion.
Yes.
So we'll have to move on to something very interesting which you brought up. I have a question for you that, one of the cases you showed that IHRF is one of the predictors, and I was wondering that if you have gone through literature where Jordi Moniz showed one of the interesting biomarker called drus and ooze.
Yes.
So how do you differentiate those IHRF from drus and ooze, and how do you follow them up?
So drus and ooze is also a sign of RPE distress. That is that since the RPE is no longer viable, as in no longer nutritionally supported by the choriocapillaris and atrophy is setting in, the RPE kind of oozes into the intraretinal space. I have seen in that publication, correct me if I'm wrong, that drus and ooze usually has a very small RPE aperture from which it comes out. That RPE aperture and those drus and ooze tended to be a little larger than this IHRF. Also, I have seen drus and ooze in adult onset foveo-macular dystrophies and even like pattern dystrophies. We have seen those drus and oozes and RPE aperture, and they may signify that very soon this patient will have atrophy.
Yeah, that is true, and I think this is very important that we learn to differentiate, because these fine HRF can be different from ooze, and HRF seems to be much more or a stronger predictor for atrophy. Yes. And I had one more question, that one of your patients you showed
can
that...
Can we have the slides, please?
One of your cases you showed about a big, large drusenoid PED. So I know that we all really freak out as soon as we see a large drusenoid PED. Then in those cases, may not be this one or the one which Rahul was showing in the last presentation. So how do you follow these patients? Because we know that they are certainly going to progress and pretty sure that they will end up into atrophic cases. Then how do you follow them up?
So I think that is the most important question for this talk. So drusenoid PED will require much more frequent follow-ups as compared to other markers like drusen. If we follow up hard drusen or even soft drusen, maybe 6 to 8 months follow-up, but a drusenoid PED, especially if they are showing signs of acquired vitelliform lesions or IHRF, they need to be followed up. But however, it's just a trailer for Cirrhosa, and there's not much we can do. We can just prognosticate and tell the patient that this is likely to happen.
So if this audience wants to know which single predictor which makes you worry about atrophy progression, which one do you pick?
So I will pick IHRF. And IHRF, especially in the setting of a drusenoid PED, when it's at the apex of a drusenoid PED and it has moved intraretinally, that and AF, IHRF in a combination with FAF pattern will be very important to prognosticate.
So we have to target our drugs all towards HRF. Any comments from the audience?
We have subsequent talk on KPLS. I think KPLS is also an extremely important predictor of GA occurrence and progression. So I think that is also a very important marker as far as prediction of GA is concerned.
That is
interestingly, thin DLS and say drusenoid PED at the same location tend to be mutually exclusive. Thin DLS seems to be an independent risk factor, whereas soft drus and drusenoid PED, HRF seem to be a little, they have a different path, I think, both of them. So at least what I saw in a couple, like 15, 20 of my patients was that thin DLS seemed to follow, ultimately the destination is the same, but the pathways seem to be a little divergent.
Yeah, and I think when we talk about DLS, we may be able to discuss more on that topic. Any other questions? Please.
Yeah, I have a question as a totally novice. So what? So fine, like this is what it's going to be. So you tell the patient you're going to become blind in the next 3 weeks or 3 months or whatever. So is that what it is, or is the drugs going to make a difference?
I think that's exactly where we are. We are at the cusp of coming up with newer drugs which will be targeted towards the early biomarkers such as HRF and EZ. And I think that's the goal, is that today we are talking about Syfovre and Izervay because now we have drugs. In 5 years we'll have something which we will be treating our patients before even the CRORA establishes. So that's the whole idea of coming up with predictors.
In the existing situation, would any of the drugs which are available make you treat at a particular stage? That's what I wanted to know. So if it's IHRF or drosenoid PED, do you start at that point in time, or when do you do?
I'll let Marian start, and then I'll start my US pain. He needs a microphone.
I just want to comment on the so what part. If we look at feature importances and predictive biomarkers for that, you see that a lot of predictive biomarkers for GA or that progression to GA is similar to the progression to MNV or neovascularization. There are only a couple of biomarkers based on which you can really differentiate which way the eye will go. So I think if we see kind of these biomarkers, this does not only mean that the patient may progress to GA, it also may mean that the patient may progress fastly to MNV. So I think these are the biomarkers where you need to kind of see the patient more frequently. Irrespective whether we have treatment for GA or not. It's just an activity marker.
Dr. Gopal.
This is just a question that if you see high refractive foci, you say it is predictor of future geographic atrophy in the presence of drosenoid PED. Is there any way you are able to link them pathogenetically? Why should a high refractive foci indicate that RPE is going to collapse next day? Is there any pathogenic indication?
So I think that a lot of theories people have tried to relate it with whether it is complement inhibition or whether it is inflammatory. Adnan?
Just to respond to that last point, so the notion is what's happening with the RPE differentiation. One of the common pathways of aging is cells lose their identity. And when the RPE loses identity, it can lose its ability to bond to layers below, and it can therefore separate and migrate. Hence you get defects with drusenoos, the RPE cells migrating. So they are RPE cells, and Kristen Clusio has got some correlates of that now. And where you're looking at that in aging RPE cell models, and that's actually what's happening. But that's all part of the continuum of going into the GA, where your RPE cells is losing its identity. What we don't fully understand is the expansion yet. So that's what the lab group is doing at the moment.
And I may add here what is important, because this kind of losing identity is like the epithelial to mesenchymal transformation of the epithelial cells, and this is partly reversible. And this is also an important part.
Yeah, there are therapeutics looking at that.
Yes.
Which is why we're interested in it.
So we will be talking more and more about GA in coming years. So just be on top of this, because there are more therapies coming up treating these patients much earlier. Thank you so much, Apoorva. We will